In this video, I'm going to answer your questions about MS relapses, new spots on MRI, and progression of neurological disability. It's a pretty heavy topic, so don't turn away. That starts right now. Howdy! Thanks for learning about MS with me, Aaron Boster. I'm the founder of the Boster Center for Multiple Sclerosis, where we care for families impacted by MS from around the globe. I love answering your YouTube questions, and recently I had a blast doing an impromptu Ask Me Anything YouTube live stream. Unfortunately, I didn't get to all of the questions, and in today's video, I'm going to tackle several really intense questions asked by viewers. So let's jump in. Our first question comes from Tamara Mohammed, who writes, "One relapse every year. Do you consider DMT working?" That's a pretty important question. Now, the quick answer is absolutely not, but I want to unpack this a little bit. When you're taking an oral birth control pill to prevent a pregnancy, and then you get pregnant, it didn't work. And so if you're taking an MS medicine to prevent an MS relapse, and you have a relapse, it didn't really work. And none of our medicines are perfect. None of our medicines are 100%. So we can't have a complete zero tolerance policy all the time. What is a realistic expectation for the number of attacks that someone should experience when taking a DMT? When I was in training, I hate to say quite some time ago, when we only had shots, the first line injections, interferons and Copaxone available, I was taught that one attack a year was acceptable because our medicines weren't very good. But in 2021, things have changed dramatically. And our expectations for placebo, meaning people not on therapy, is to only have an attack every 3 years. So having an attack once a year on a drug is abysmal. It's really, really not okay. When you look at some of the newest and most effective disease-modifying therapies, and you look at their attack rates, you're looking at numbers like one attack every 5 years, one attack every 10 years statistically. And so I would submit that one attack a year is a complete failure of that medicine, and I would most certainly be talking to my neurologist about an upgrade. Just my 2 cents. Sally writes in, "I prefer not to take IV steroids for a relapse with less severe symptoms. What are your thoughts?" Sally, my first thought is it's your body, it's your brain, it's your disease, and you don't have to do anything you don't want. I tell my patients, if you have new neurological disease activity, I need you to call me and tell me about it. Now, I might in turn say, "Ooh, that sounds like an attack we need to treat," and you're allowed to say, "I don't want to." And I'll say, "Okay," because it's your body. Now, my opinion, however, is a little bit different. If you have a new neurological deficit from an MS attack, then I'm concerned about unchecked active inflammation in your head, and I want to quell that. I want to hasten the recovery. Now, there are old papers that suggest that whether or not you take steroids does not change the long-term outcome. And I have to tell you that I don't really believe those old papers. I can't fathom that if you quell inflammation, if you stop brain damage from continuing, that it's not good for you long-term. I don't want you to have the event in the first place. But if you have it, I am voting that we give steroids to hasten the recovery. Now, that's just my 2 cents, and it doesn't make me right. It just makes me really opinionated. The take home here is you're in charge of you, and I hope that you bring these things to the attention of your neurologist for a conversation. Abdul Majid writes, "I have had MS for 10 years. I'm in good condition. I'm concerned about the long-term effects of the spots on my brain. Will they affect me after 15 years? That's a very insightful question. When you think about what a spot on your MRI is, it's actually an area of your brain that has been damaged from autoreactive cells causing inflammation in your noggin. And oftentimes, I think we pay the devil's price. We pay twice. So you have a new spot in your brain that causes temporary dysfunction, an attack, and then your body rewires itself. Your brain rewires, and so you get better. But that area is still damaged. And as your body ages and as your brain ages, that area can wear out. And that's the underpinnings of progression. To understand this concept better, I'll throw a link up above to a video I've done on Stephen Krieger's leaking pool model of MS, which I think goes into this in some length. Now, what can we do? Well, number one, we can take great efforts to prevent new spots from occurring. We can not smoke things. We can take vitamin D. We can exercise as part of our lifestyle. And we can take the most effective DMT possible and make sure that it's working. These are important things. But if you have damage that's already occurred, what can you do? You can pay close attention to brain health, making sure that you're removing any cardiovascular risk factors in your way. You can stay physically and cognitively active. That's going to set you up the very, very best to do the best long term. It's an important point, and I really appreciate you bringing it up on this channel. Thank you. Longtime viewer Ichabod13 writes, "Morning. Is there any chance of symptoms getting better after lasting months or years? It just feels like everything's slowly getting worse and not getting better anymore." Your question is an interesting one, and I've had unique experiences where a chronic symptom, which I was certain would never ever be removed, goes away. Now, it's not common, but I have seen it, and so I want to share with you now. There's a gentleman that I take care of, a great guy, and he had a very unpleasant symptom, Lermite's phenomenon. So when he moved his neck, he would feel electricity running down his back into his feet, and he hated it. But he didn't want to take a symptomatic medicine for it. And each time he would come to see me in clinic, he would bring it up, and I would show him his MRI. I would show him the lesions on his dorsal spine. I would say, "Look, man, it's caused from this lesion. I can't make it go away." And he would kind of move his head in a rigid fashion because he didn't want to trigger it. We gave him a highly, highly effective induction medicine for his MS. And to our surprise, after 7 years of this symptom being present, it went away and it's never come back. Now, that's not normal. That's not a normal occurrence, but I have seen it with my own patient. So I'm just sharing that with you because I think it's really awesome. Another thing that's maybe more germane is the fact that we can improve chronic symptoms. So all too often, I feel like we focus so much on disease modification that we don't spend ample time trying to improve quality of life by managing symptoms. So if the symptom that's bothering you, for example, is spasticity, maybe we can be more aggressive at treating the spasticity. If the symptom that's bothering you is cognitive fatigue, there's all kinds of things we can do to improve cognitive fatigue. I don't think we need to settle for what's currently going on, and I think we're allowed to ask for better. Just my 2 cents. Chris writes in, "I'm a software developer with executive functioning and cognitive difficulty due to MS. How do we know when it's time to go on disability?" Chris, this is such an important question, and I want to start by thanking you for asking it. Your job is cognitively demanding, and it's true that people impacted by MS can develop cognitive dysfunction and cog fog, and it can really make it hard to do your job. And I think that you're being very responsible asking the question, hey, when should I not do this, or should I not do this at some point? I think one of the most powerful tools possible in helping answer that question is getting neuropsychometric testing. Formal neuropsychometric testing is the real deal Holyfield of thinking and memory. It's a 3 to 5 hour battery of tests administered by a technician. It's really the end-all be-all for thinking and memory in all different flavors and forms. And what it teaches us is super valuable. It'll give us a readout and share for your age, gender, educational level, here's how you perform compared to a bunch of other people. And we'll invariably identify several things that you do way better than others. We'll identify a bunch of things that you do as well as others, and we might identify a couple things that you don't do very well anymore. And if we can figure out the things that you're really strong in, we can sometimes come up with compensatory measures to help then improve the stuff that you're struggling with. This is also very helpful because if, in fact, you have cognitive decline, the test can then be repeated a couple years later, and with great certainty, we can prove that the problems that you're having are from your disease. And this can become very, very helpful if and when you do seek out disability down the line. Consider getting some neurocognitive testing, some neuropsychometric testing to help you with a baseline, to help develop a plan for cog rehab, and, God forbid, down the line, if it gets worse, to set the stage to demonstrate that it's from your MS. If you'd like to learn more about MS relapses, click the video that's on your screen right now. My name's Aaron Boster, and as always, thank you for learning about MS with me. Until my next video or my next live stream, or the next time I see you at the Boster Center for MS, be safe and take care.